Hi everyone, and welcome to Anesthesia for Neurosurgery. And yes, this is a tute I give every year, and it's one of those interesting things that the last time I did neurosurgery, cranial neurosurgery, was a pretty long time ago. So I really encourage you guys who've done it more recently to me to just offer whatever insights. If you're doing something different at Austin or Royal Melbourne or Alfred St. or wherever, please let me know, because I update these slides every year based on the input of you guys. So essentially, what am I going to give with this lecture? Look, I've taken all the information that I knew for my part 2. I don't think too much of it has changed. A lot of things in anesthesia move fairly slowly. New evidence takes a long time to actually come through, but it's not like there's new stuff and new techniques coming out every day. We do a lot of the same things. But what I really want to offer is structures and techniques for the exam. As much as I think, I think this exam is a game. I think there's certain aspects to the exam that you just need to prepare and plan for. And hopefully that's what I'm going to give you guys today. So yeah, please tell me if you guys do anything, especially I do a little section on awake craniotomy, and I've never done one of those. There's always someone who has done it. It'd be really great. I mean, just now, has anyone done an awake cranie? Nope, that's right. We can muddle through that together, at least know the principles. So let's get started. So I do a Viva Bootcamp exam prep course. You'll find the details at that website link over there, anesthesiacollective.com. And then I'll put all of these lectures up, as well as there's a whole part 2 playlist on ABCs of Anesthesia, the YouTube channel, as well as the Viva Bootcamp sample stuff. And then, I'm just loading up Vivas that I'm giving people. So essentially, if you want a Viva, just come to me, but it'll be on YouTube and a podcast if you don't mind. And that way, you wouldn't believe how many people really want to see this stuff. It's just a bit of a discussion in a Viva style format, and we just go through a lot of content. But I'm literally just making Vivas about certain topics based on the latest evidence, and pretty much just learning myself and asking the person questions as well. So that's me. The first thing is, obviously I'm going to be asking lots of questions. That's just the style of, I think, how best we can learn. So, I assume that you guys are all brilliant. You're not just in medicine, you're in anesthetics. So, if you sometimes you'll say a great answer, sometimes you'll say something you wish you'd said differently. No one cares. I don't care. I just want you to, get past this exam and have an amazing life as an anesthetist. That's it, pretty much. I hope you feel very okay if I, ask you a question or pick on you. So this is what I believe the Viva is, knowledge and techniques, Viva frameworks, and then MCQ. So we'll try to cover as much of that as possible. So we'll go through subarachnoid hemorrhage, vasospasm management, intraoperative rupture, AVMs, head injury, C-spine, positional issues, ICP monitors, awake cranie and craniotomy, and then Viva framework and transphenoidal issues, and then Viva framework stuff, so pre-op frameworks, anesthesia knowledge, crisis management stuff, and a couple of trials, and then probably won't cover too many professional document issues in this one. And I've got a whole bunch of scanned answers up to about, I forget, 2008 or whenever they stopped releasing papers. So feel free to ask me for those if you'd like. But let's get started. Again, any questions at all, please, please interrupt. That's not a problem at all. So we're going to cover all the core neuro topics, have a concise format to answering the tough and broad questions, hopefully compile a comprehensive set of notes. So, get your pen and paper ready, so I'll ask lots of questions, and get you to write stuff as well as speak stuff out, and get a taste of SAQs and Vivas. So again, lots of questions, SAQ practice, Viva answers, and systematic ways of answering questions. Now let's start with subarachnoid hemorrhage, because I feel like that's one of the highest yield topics in neurosurgery. So now, I just think about what happens if you ever get a question that, like, for example, in the short answer question, you might be asked to just talk about subarachnoid hemorrhage in whatever context. You want to be able to write out something quickly about the demographics of something. So I thought subarachnoid hemorrhage was a good way to, I guess, present information. You may not have read this recently, but I want you guys to know in the next 2 minutes, just write out the basics or the background factors of what you think subarachnoid hemorrhage is. And I might and might pick on you, Diana, at the end of a couple of minutes. Sorry about that. So the way I frame this, if I'm thinking about basics, to cover as much things broadly as possible, think of who this affects, when, what age this affects, where the lesion might be, generally speaking, why it happens, maybe the how of it happening. And just try to get that together. So take 2 minutes now. What do you reckon?
Okay, I'll see what I can remember, but probably half of this is going to be wrong. But essentially, so I guess I associate it with hemorrhage within the subarachnoid space, seen on a CT scan. Typically, maybe due to like a ruptured aneurysm, like a berry aneurysm, or maybe malformations. I think it might, correct me if I'm wrong, is there a female preponderance to it?
There is. Nice one. Keep going.
Like age 30 to 60-ish?
Yeah,
and then associations, I just wrote down ECG changes, and prognosis, I think, depends on like Fisher score and GCS.
We'll go through that in a second, but that's good to mention there. So yeah, keep going. Do you know which part of this circle of Willis it might affect?
Middle cerebral artery.
Middle cerebral seems to be the answer for everything except this one. It's anterior.
Okay.
So yeah, peak female, greater than males, and it seems like it seems like every time I give a situation of a subarachnoid, I've heard of it, it's always the female case scenario. So, and you're right, 30s. The only thing you did wrong there, like say you said, I think it's around in the 30s to 50 or 30s to 60s. That's far better than saying 30s to 60s inflection. You can get, I think the examiners know that they're not going to be on top of everything. So I want you to just in general, especially in the exam, obviously not now, but just go, 30s to 60s. That seems reasonable. Anyway, peak 50s, incidence 2 to 5% seems high. 89% are in the anterior circulation. And you're right, it's associated with aneurysms and AVMs. You mentioned exactly the top two things. By the time you've got to this exam, if you remember something, it's probably right that you are correct. Also vasculitis and dissections. I'm just going to pick on something else now. Is it, Matt, besides aneurysms, AVMs, is there any other conditions, Matt, that it might be associated with?
Well, I didn't initially put it into traumatic and non-traumatic.
Oh yeah, good.
But then within most of what I wrote down fell into non-traumatic. And so then I thought associations being things like hypertension and connective tissue disorders. So people that are predisposed to having pathologies with their vessels anyway.
Fantastic. And that's great. Okay. So you could almost just guess that the fact that, vascular lesions are often hypertensive related and all these other things, Ehlers-Danlos loss. And these are kind of connective tissue disorders, essentially. Polycystic kidneys, coarctation of the aorta, Marfan's, and this crazy hereditary hemorrhagic telangiectasia. Imagine getting that out in the exam. Nice. Hey, Kirsten, I might ask you about prognosis. What do you reckon? But you can take your mic off. You can give me a general. Don't worry about numbers. Just give me.
Sorry. Also, just excuse the screaming toddler in the background.
Oh, we love that.
It's keeping it real. I actually don't know prognosis. I haven't looked at it for a long time.
Yeah, that's right.
I'm thinking, intervention versus non-intervention. If someone gets treated or not treated, but I couldn't tell you numbers. I don't know.
Yeah, that's absolutely right. But I think you get the feeling that this is. Would you say the prognosis is good or bad?
Poor.
Yeah, exactly.
Poor prognosis. Yeah.
Often it's poor prognosis in general. So die before hospital. That's obviously poor. Not many, in other conditions will die before hospital. Of the remember, 25% die in the next 24 hours. It's really sad, really.
Oh, terrible.
10, 25, and 40% make a good recovery. From this data, it says age, conscious state, and the amount of blood are the kind of prognostic factors. This is just an example of if I use some kind of format like the who, where, when, how, why, and how, I can just get facts out that even if I didn't, just about I thought about, okay, this affects females more than males, I'll write it down. The problem with this exam is you don't get all the visual cues. And a lot of the structures I'm going to give you are so that you remember to say stuff that you already know in the back of your head because you're not there with the patient getting sense, essentially getting triggers to mention things constantly. So that's a lot of what this exam is about. And that's why it's a bit unrealistic, but hey, this is the game we're playing. Okay, classification. You probably got a hand up, it doesn't matter too much. Do you guys First of all, I might ask, sorry, Sharon, I'm sorry to put you on the spot. Do you know what classification systems we have for for subarachnoid hemorrhage?
So there are some clinical classifications and a radiological classification, and that's, I think, more related to the aneurysms and subarachnoid hemorrhage. So the clinical classification one is the Hunt and Hess, which I don't remember really. And the other one is the World Federation of Neurosurgeons, which incorporates the GCS score and whether there is a focal neurological deficit.
Yep.
And basically, it predicts the outcome depending on where on the classification scale it is. And the radiological classification is based on the CT scan, whether the size of the bleed, I think, is one of the things.
Sharon, I gotta say, that was actually a really great answer. And the only thing I wish you'd done is be really confident about it. Because that was actually a really good answer. So, no, well done. Okay, I feel like the World Federation of Neurosurgery score is one of the more recent ones. 1988 versus, I think, 1968 was when Hunt and Hess was developed. Can everyone write down as best as they can using kind of the categories as gradings of 1 to 5, GCS on one column and focal neuro deficit on the other column. Just do the best you can. I'll give you 30 seconds to do that.
So grade 1 is 15 GCS with no motor deficit, and then grade 2 is a decrease in GCS down to 13 and 14. Mm-hmm. Grade 3, you add the motor deficit, but there's no change in the GCS. And then the last 2 grades, you just go down GCS and you may or may not have a motor deficit. So it goes from 13 to 14, 7 to 12, and less than 7, I think, from memory.
Yeah, that's great. So fantastic. So the WFNS grade, probably one of the more recent ones, and that's exactly right. So GCS on one axis, 15, 13 to 14, 13 to 14, 7 to 12, 3 to 6. Obviously, there's really big groupings here. 7 to 12, there's a big difference between 7 and 12, especially when you think 8 is intubation, and then 3 to 6. Obviously, problems with all of these classifications. And then, as you said, absent for grade 1, motor deficit, that is, absent for grade 2, present for grade 3, present or absent for grade 4 and 5. It doesn't matter. That kind of GCS is terrible. Just to quickly go through Hunt and Hess, this is, it's just, there's different axes that people are measuring the severity of these grades, but the fact is that it's just so, just quickly, Nicole, what's the problem with Hunt and Hess?
That's a good question, actually. I presume it's fairly subjective in terms of the symptomology.
Yep, great. It's subjective, and if someone's not, having uniformity of severity in all the different categories, then, how do you grade it? So there's a lot of subjectivity in which category you put them in. So I think when they put out the World Federation Neurosurgery score, that they tried to combat that. What is the point of these classifications?
Well, firstly, I think you can then do interval assessments to see if there's been any changes, but also it gives an indication probably on prognosis.
Yeah, that's right. And the reality is that, it actually isn't that great for prognosis. There's a lot of overlap. I was just reading a paper recently that was saying how, sometimes there's no statistical difference between the prognosis of 3 and 4 or 2 and 3. So there are problems with it. It's not perfect, but, this is more important for you to know these grades more than anything else, really. Does anyone want to volunteer actually, everyone have a go. Write down the Fisher classification. That's the radiological classification.
Sorry, is this Fisher's classification for subarachnoid?
Yeah. Who is
it's a
iPhone 11?
Hey, sorry, I'm on post nights and I'm video off. Sorry, just because I look horrible post nights.
Yeah, all I've got is an iPhone 11 p.m. That was very time.
That is me.
Go for it, Ange.
It's a radiological classification of severity of subarachnoid hemorrhage, and it prognosticates the risk of delayed cerebral vasospasm.
Fantastic.
Yep.
Great. 1 is no blood, 2 is less than 1 millimeter thick, 3 is greater than 1 millimeter, 4 is any intraventricular or intraparenchymal extension. And yeah, it tries to prognosticate for vasospasm. Do you know what the problem with this one was?
Purely radiological and doesn't take into account clinical.
No.
How do you know they've had a Subarach with this one, unless you've done an LP? If they're a grade 1, if there's no blood seen. It's my issue.
Yeah, that is a problem. Ask your friendly neurosurgeon. Is maybe they have had a lung puncture and everything else about their history points to it. I mean, a lot of what we do is probability, but there's the risk of vasospasm in this on the studies for this actually decreases for grade 4. So it's always a little bit iffy about that. It goes from like 37 to 31%. Now this is from Radiopedia. And they just talk about these grades and how incidence of symptomatic vasospasm, gradually increases, but there's a very odd problem when it decreases in grade 4. So they've done another modified scale, which I don't know very well. I think it's probably just worthwhile knowing that there's a modified Fisher scale and it tries to account for this. But I doubt you'll be asked that. Prognosticates for vasospasm is a CT guided score. Excellent. Any questions about that? I don't think you have to know too much about it. I think that's the bare minimum what you have to know. And, you can, like a lot of things, you can study these scoring systems at length. All have issues with prognostication, which is the point of the first two. There's variability of use at different centers. Hunt and Hess, it's very subjective, but a lot of the older papers were all Hunt and Hess classifications. And some of the more detailed classifications have 14 axes, and they're just not very practical to use in a day-to-day setting. Okay, so let's move on. So Viva and SEQ technique. So if you get asked the question, how do you assess any patient? The common thing that we get taught is history examination investigation. And I think this is amazing. This is exactly what we do. We use our voice to get a history. We use our eyes to, look at all corresponding, all the, EMR records and all that kind of stuff. We do an examination. We get, use investigations to get all the extra information. And those are really our information gathering tools, but any medical student can do this, right? So I want to just ask you about another system that we can use together to make sure you obtain all the critical information in a case. I'm a 50-year-old female with a subarachnoid hemorrhage that you're coming to see in ED. I want you to just ask me lots of questions, not anesthetic questions, but just about my subarach.
Just about your subarach.
Yeah, and my subarach related medical history. So we're going to keep it non-anesthetic, past PONV, malignant.
Sure. Okay.
Cool.
Can you tell me what's brought you to hospital today?
Yes, headache.
Headache. When did the headache start, please?
Just started an hour ago. Came straight to ED. Yeah.
What can you describe the headache for me?
Yeah, very sudden, worst headache I've ever had, back of my head.
Okay. Any pain anywhere else?
No.
Okay. Have you noticed any other changes in terms of weakness or sensory changes in your body anywhere?
No.
No. Okay. Have you ever had a headache like this before? I think you said this was the worst one you'd ever had.
Yeah, never had a headache before.
Okay, sure. Is the headache getting better or worse?
It's about the same. It's about 10 out of 10. No radiation.
Okay.
So that's good.
I ask?
I just want to first say that's great because you asked me the pain questions. I remember being in a basic surgical training exam as a bulldog, and none of the surgeons ever asked all of the pain questions, and that meant that maybe one did, but it meant that they didn't diagnose a tumor instead of a subarach or something like that. Like they just didn't ask the periodicity or the onset of it. So really important. But keep going.
Sure. May I ask you questions about your other health issues, or do I need to stay on the subarachnoid?
No, other health issues. Yep, absolutely.
Okay. Can I ask you if you've got any other medical problems?
High blood pressure.
Yep.
Yep, that's about it.
Do you drink alcohol?
No.
No. Have you ever used any illicit substances like cocaine?
No.
No. Are you on any medications at the moment?
No.
No. Has anyone in your family had problems with blood clots or bleeding in the brain that you are aware of?
I think they had actually, yeah.
Okay. Can you tell me about that? Are there any diseases that run in your family?
I don't know exactly about what disease runs in the family, but I feel like there was something in the past.
Okay. All right. And when this headache came on, was there, had you had a fall? Was there any particular event that brought the headache on, or it just came out of nowhere?
It just came out of nowhere.
All right.
Yeah, good.
And then I might ask you about whether you've had any chest pain or shortness of breath.
I have actually, yeah.
All right.
Why are you asking
that? Because subarachnoid hemorrhages are associated with ischemic changes in the heart, so you can get SG changes on ECG, and also associated with neurogenic pulmonary edema.
Excellent. And Carolyn, you're actually demonstrating my point very well. So now, what is your framework at the moment? Like, as you're gathering information, are you thinking about it in any specific way?
Sure. So just asking about history of presenting complaint. So asking about all of the questions around the headache.
Yes.
Then thinking about what else it could be and asking about associated risk factors for the disease.
Yep.
And then, really just asking around things that are going to support my hypothesis for what you've got. And rule in and rule out, or not rule in, rule out, but to help me grade severity of
perfect
of the subarachnoid.
You actually did more than that, in fact. So you were taking
stability, yeah.
So this is the framework that now I think a lot of people talk about. When we started discussing this as a framework in our study group, severity and stability was just this thing that one examiner kept talking about. We're like, okay, sounds like that's what they want to hear. So everything became severity and stability. But then we thought, well, that's not really enough, is it? Like, that's the disease itself. That's part of the history of presenting complaint. But what happened to it, that's like the risk factor and cause. So you correctly were asking family history. Have you had anything before? Has anyone else had anything before? And you're exploring that. And imagine if you then know all the associations, you might say, look, I'd check for a history of Ehlers-Danlos loss or connective tissue disease, hypertension, AV malformations. When you're in this exam, you don't have all the cues that you'd normally have, which is the full GP assessment of, all the medical history and a cardiologist and maybe the medical team already coming in doing their really awesome physician history, which I'm never going to do in that detail. So that was really great. So in this exam, if you don't use this framework, I believe you won't just naturally get out these points that you would otherwise, otherwise miss. But you also asked about then complications. You said, are you getting any shortness of breath or chest pain? So, subarachnoid hemorrhage is just ripe for complications. And so again, there's a great example of, I'm not just going to think about the disease now, I'm going to think about what caused it, and I'm going to think about what it will cause. And there's a whole bunch of stuff that will go in complications. And then, of course, you asked me very specific things to help you grade severity. You already knew my GCS was 15, but you asked about any weakness. So you went, straight for the motor deficit stuff. So when you present this now, you can easily go, oh, this patient has potentially a grade 1 subarachnoid, or what seems to be a grade 1 subarachnoid based on the history. We'd confirm that with a CT scan. It's new onset, so it's unstable by definition, needs assessment. Some family history of headache and bleed may be part of the cause of this, and she's got hypertension and not complicated by anything that I could tell, or they do. I've just added here then specialist management, specialist meds, because there's such important things now that the progression of management can cause its own set of problems and complications. So that's the framework that I use. And I thought I'd just give that, if you haven't heard of it, something I do in every tube, because I think it's just really, really valuable. Okay, so how do you get to the crux of the questions? The points that differentiate this patient from any other assessment. In addition to my standard preoperative assessment, I would assess all of these other things, which you went through very nicely. And essentially, severity we've talked about, that I'd try to get a grading through my history of the WFNS grading system and the Fisher score. Stability, I'd look at the GCS, your vital signs, heart, lung, and I'd look at the cause. I'd look at all the complications and management of early or late clipping. What are the complications that you would see or expect to see at subarachnoid hemorrhage?
So recurrent bleeds would be the key thing you want to avoid.
Yep, sounds good.
70% mortality, delayed cerebral vasospasm,
yep.
Seizures, neurogenic pulmonary edema, cardiogenic, heart failure, I suppose, and SC changes. I think other later things is you can get become febrile from it. You can also get electrolyte abnormalities, particularly sodium. Coiling herniation, hydrocephalus, and then in the longer term issues with like DVT mobility and permanent impairment.
Sounds good. I'll stop there. Yeah, great. So I've got here, for some reason, I just had this as my mnemonic, RVEHM, and it just stuck in my head. So I've just put it there. You know, I used to have just a whole bunch of really stupid mnemonics, but hey, if they work, they work. Rebleed, absolutely. Vasospasm, absolutely. Epilepsy or seizures, hydrocephalus, and the medical issues, which includes all the electrolyte problems, the cardiac problems, and the lung problems as well, because these patients are predisposed to what seems a lot of issues. Yeah, good. I think we'll go through the other stuff in the next few slides anyway. In light of we're trying to extend our history to get as much out of it. Say if you have Marfan's or hereditary hemorrhagic telangiectasia, that could predispose you to a subarachnoid hemorrhage. I can just imagine on a Viva you getting this and you're absolutely smashing it because now you've thought about it. What do you have to worry about in anesthetics if you have Marfan syndrome and hereditary hemorrhagic telangiectasia? Does anyone want to have a go at this? What anesthetic issues would you have specifically?
I can have a crack at that if you want. I mean, related to Marfan's, it's a multi-system connective tissue disorder, but what we pay most attention to is aortic pathology and associated aortic regurgitation or aortic valve pathologies.
Yep.
So any cardiac history would be particularly concerning, especially if this person was then becoming profoundly, hypertensive or having a hemodynamic consequences of the subarach could worsen their aortic pathology and aortic regurgitation potentially. Beyond that, they can have airway changes, so we can be particularly worried about airway management in them. And then
have high arch palate.
High arch palate. They can have obstructive sleep apnea, and they can potentially be difficult airway.
Yep. I've got one more thing here that they've got they can get a lung issue more commonly.
I can't remember the lung issue that they have. Sorry.
Sorry, they got a higher incidence of pneumothorax, but that's great.
Yeah.
So what we got here, high incidence of pneumothorax, but you're absolutely right. Aortic dissection, aortic pathology, this is all more common. Mitral valve prolapse, conduction abnormalities, especially bundle branch block. But those are the big things, and those are the things that would be very important for you. So that's great.
And then for HHT, I was just lucky I came across one of a women with this at the women's, but essentially they can develop AV malformations in all body systems, and so it's extremely concerning. Really for anything. So they can have these in the spinal cord, in the epidural space, in their liver, in their lung, in their brain.
Wow.
Really, you name the organ system, and they can have them. So you're at risk if you're using anything with a needle.
Yeah. Okay. That's great to know. So yeah, autosomal dominant genetic disorder, and that's really great that you've seen that case, because you never forget it then. The amount of assessment you'd have to do. Did they essentially get a pan scan to show where these, like, to document or map out?
Yeah, they did. They essentially had to have a contrast MRI, because if they wanted any neuroaxial technique, we wanted to make sure we weren't going to skewer a AV malformation.
Wow. And what was the contrast MRI? What did it show? Did it show?
I didn't show anything there. It showed minimal disease, but
that's good.
Yeah, but the woman the main thing that they get is they come in with recurrent GI bleeds, and so they have AV malformations in their gut, so they can often have hematemesis melina, and that's when they're often diagnosed. And then
good. So that's great. So essentially hypoxemia due to shunt if large, especially, and what we mentioned about gut bleeds. But that's really interesting. I didn't realize that they would do such an extensive scanning and test. That's great. Okay, let's so we've noted down some complications. So look, I actually want everyone to have a go at this. Write down each of the complications and just a few facts about each. So those complications were rebleed, vasospasm, seizure risk, hydrocephalus, and then the medical stuff being electrolytes, cardiac stuff, neurogenic pulmonary edema. Just take 5 minutes now and just write down as many facts as possible. Maybe just tell me about rebleed and ischemia, and we'll go to someone else after that.
Yeah, okay. I'm not particularly sure because I haven't studied and I've not done neuro-anaesthesia based on my old ICU.
Yeah, no, that's right.
I think the rebleeds are normally the main cause for prolonged ICU stays, and also the need for recurrent surgeries or craniectomies at some point, and also the highest risk of mortality as well.
Yeah, what's that?
And if I'm not mistaken, it's the highest risk of rebleed occurs within the first 24 to 48 hours. And every time it bleeds, the risk increases a bit more for another rebleed. So it just keeps happening, I think.
Yeah, no, that's right. So yeah, it's the main cause of mortality. And you're right, 4% in the first 24 hours, then 1% per day for the next 4 weeks. So you're actually right. Your gut feeling about that was right. Happens, worse, more common initially. What is the risk of death if there is a rebleed?
I think it's like 50 to 80% mortality or something.
Yeah, that's about right. So it's about 60 I've got here, but that sounds like a reasonable range. So it's really high. Do you know the formula, the transmural pressure gradient? Does that come to mind? No, that's right. Transmural pressure gradient. So mural being the wall. So the pressure across the wall being the vessel. So if that pressure gradient increases, then you have an increased risk of rupture. And that could be because the blood pressure goes up or interstitial pressure goes down. So imagine, a spike in blood pressure or you're decompressing the brain. So suddenly there's a change in that transmural pressure gradient. Good. Let's see, might just go to the next person. Hey, Harsh, do you want to tell me about cerebral ischemia or vasospasm and vasospasm?
Yes, my understanding is vasospasm is specific to aneurysmal subarachnoid hemorrhage. So you don't see it in traumatic subarachnoid hemorrhage. I think it was sort of days 7 to 14, I think, are the highest risk.
I've got 4, but that sounds about right. So 4 to 12 I've got here.
4 to 12, okay. And so I suppose there's kind of prophylactic management for vasospasm and then active management for vasospasm. And there's kind of non-pharmacological and pharmacological and invasive therapies. Probably the most common, and it may present with a drop in GCS or focal motor deficits, essentially pertaining to whichever part area of the brain is vasospastic. And I think it's thought to be related to irritation of the vessels due to the blood in the subarachnoid space.
Yeah, I'm so sorry, I'm wrong. Begins day 3. Wanes by day 14. So I think you're okay. Mixed up. Yep. So about 70% of patients and 30% are symptomatic. And tell me about your treatment and prevention.
Kind of the mainstays, that Triple H therapy that people talk about. So hemodilution. So keeping the hematocrit low, hypertension, hypervolemia. So often they'd try to fill them with several 2 to 3 liters at least a day. Some people had CVP targets. Sometimes they'd end up being in intensive care just for noradrenaline therapy, just to elevate their MAP. Particularly if they'd had recurrent vasospasm, they might more aggressively treat them with Triple H therapy. Nimodipine. Sorry.
You'd have CVP aims like say 10 to 12. Hematocrit 30 to 35%, MAP above 15%, or systolic blood pressure when they're clipped of 160 to 200. So, obviously these are really high aims. And as far as I know, hemodilution to that level isn't really prescribed anymore. And we're not really aiming for this level of hemodilution anymore, as far as I remember. Keep going. Nimodipine.
So the nimodipine is kind of the mainstay of, I think there's reasonable evidence that reduces the risk of vasospasm. So it's like a 4-hourly dose. It's pretty frequent. Often that can also affect the patient's hemodynamics. So sometimes you sort of got a conflict between nimodipine and also trying to maintain hypertension. And then taking the patient urgently to angiography, and I think they can do sort of balloon dilation maybe, or intra-arterial calcium channel blockers, verapamil, and various other things. Papaverine as well, to treat vasospasm is kind of end of the road treatment.
That's good. So What dose of nimodipine orally every 4 hours are you giving?
I think it's 60, 60 milligrams Q4 hourly. Yeah.
Interesting. It is an oral dose, and that's always a bit, contentious if the patient's QCS is low, but 60 milligrams 4 hourly, starting on day 1, continuing for 3 weeks. And if you were to give it IV, how much would you need to give?
I can't remember the IV dose.
That's right, 1 to 2 milligrams an hour. And finally, it's interesting. So it doesn't show any improvements in angiographic vasospasm, but improves clinical outcomes. So they're thinking it's due to, a cytoprotective effect rather than anything else.
Oh, right.
Sure. Good. And so because we're talking about vasospasm, cerebral ischemia or infarction, that's 4 to 12 days after. It's about a quarter of patients. And again, contributing factors to that are vasospasm, inflammatory changes in the endothelium, reduce cerebral perfusion pressure, and a few other things as well. Hydrocephalus is about 25%. Epilepsy is about 13%. I might get someone else to tell me about the medical complications. Hey, Nami, are you around? Are you able to tell me a little bit just about the medical stuff, like the myocardial dysfunction, ECG, electrolytes? Actually, tell me about the electrolytes if you're there.
Yeah, sorry. Electrolytes. I'm not entirely sure. I think they can get acute kidney injury. So I would think that would lead to hyperkalemia and hypernatremia.
Maybe I don't have that as a specific thing for subarach. What kind of sodium? It's often sodium disturbance.
So I think they can get neurogenic, so SIADH.
Exactly, yeah. So SIADH, and they just treat that by volume between both. It's like 10% of patients may get that.
Yeah, is that the same as cerebral salt wasting?
No, I don't think that's the same as cerebral salt wasting. No. But you can also get hypernatremia then. So you can get hypernatremia because of SIADH or cerebral salt wasting syndrome, but you can get hypernatremia if they get diabetes insipidus as well. So your sodium balance is just all over the place. And then, then essentially ECG changes are pretty common. We'll go through that in a second. Myocardial dysfunction can be common, but I'll go through that as well. And then, pneumonias and DVT can be due to inactivity and your heart problems. There's a really good write-up on a 2007 SAQ where the examiner actually writes really great comprehensive notes about subarach, which I thought was really useful. So yeah, if you check out one, I forget which setting it was, but 2007 short SAQ papers, the examiner's notes were exceptional. Okay, CKMBs, let's say you get this patient and the CK antroponin is elevated preoperatively with some minor arrhythmias and T wave inversions. Do you postpone or proceed? I want everyone just in the next 5 seconds, just think about what you do because I want you to commit to an answer here. Imagine you're in the Viva, they give you a situation like this. Do you postpone or proceed? And I might ask, hey, Queenie, would you hazard a guess? What do you reckon?
Did you want me to answer that now?
Yeah, why not?
Yeah, true. It's not going to get any better with time. But I'm going to presume that I would proceed because I would presume that this cardiac picture is in the setting of the subarachnoid hemorrhage, which presumably isn't going to get any better with delaying it. I guess you can just try and optimize what you can cardiovascular wise, which would usually be like almost aligned to what you would need for cerebral perfusion.
That's actually good. So your gut feeling is right that, you can proceed with this, but why is it okay to proceed in this case? Like, are these cardiac changes going to be very harmful for the patient, or are they due to actual cardiac disease, or is it due to something else?
I would presume that this is due to the sympathetic nervous system surge that you get that's driven by the subarachnoid hemorrhage rather than focal problems with the heart.
That is exactly right. So your gut feeling is right again. So essentially I've got this patient with cardiac problems and signs, but they're really just due to the subarach. So it's not like they've got inherent cardiac disease. I'm not worried about a tight artery that needs to be stented or something like that. This is you know, the fact that many patients, 50% of patients will have a rise in their CK, and this is not usually associated with MI. There's little correlation between ECG abnormalities and ischemia, and only 0.7% will sustain an MI anyway. Yep. So you'd get all the usual monitoring and echo that you could get. Like, and just to give it context, you know, this is an exam about making decisions, and I feel like this is one of those typical situations that comes up in the subarachnoid cases, and so often this could easily be a thing you'll be asked. And having a way to talk around, well, you know, I think this is common due to this catecholamine surge of the subarachnoid. It's not due to intrinsic cardiac problems. It'd be safe to proceed in most situations. So,
Lahiro, can I just ask?
Yeah, please.
Sorry. So I feel like it's reasonably clear for a patient who doesn't have significant ischemic heart disease history. But if they did give you a situation where a patient who's got, you know, terrible ischemic heart disease and then obviously presents with a subarachnoid, then you just discuss risk benefit and say,
in fact, because I'm about to ask that question, you get to answer it now.
Hooray.
The next technique in this Viva, or preparing for this Viva, is to explore the hypothetical. So exactly what I've said. I've said everything's pretty good. This is normal for a subarach patient. You know, let's proceed. Now I want you to construct me a situation where you wouldn't proceed. What do you reckon? When would you not proceed? What cardiac signs or, you know, changes or whatever? When would you go, hey, let's just hold on here? Anesthetizing this patient could cause mortality.
I think that such a situation would be something where you have changes that would be consistent with an ST elevation MI. So if you were concerned that they're having a STEMI, and if that was a widespread STEMI, if they had significant history of ischemic heart disease and perhaps with a recent event, that would make you much more suspicious. And then, I mean, these patients do get cardiomyopathies associated, but if they had signs of kind of florid heart failure, I think that's hard though, because they're also going to get neurogenic APO. But if they're obviously in complete florid left and right heart failure, then I think you might have to try and optimize that somewhat before you go to theatre.
That's exactly right. So as you mentioned, the delay of surgery must be balanced against the risk of rebleed. And, you know, when you do early clipping, you essentially try to get rid of the risk of an early rebleed and vasospasm. And in most cases, the balance is in favor of proceeding. But yep, as we were mentioning, when would you delay? And I like the hypothetical that you give me. You know, give me a situation where they've had recent heart disease or ischemic heart disease. They maybe had a recent stent and they've stopped anticoagulation because of this bleed. And maybe they have ST elevation, or maybe they have like malignant arrhythmias or signs of bad heart failure. So now I've got a situation that's far trickier. So again, the aim of this, I want to get you past the easy decision that every examiner would be like, yeah, cool. They know what we're talking about. Now let's go to a more difficult situation. Okay, this patient actually has APO, malignant arrhythmias. And then it would be almost stupid. Like, you're not going to proceed with the patient having ventricular tachycardia runs, right? That would be crazy. Or if they've got florid APO with SATs of 60% needing, you know, mechanical ventilation, then how do I know to proceed? Well, that would now be a discussion with the surgeon. What is the risk? Discuss with ICU and find out how optimized I can get this patient before we can proceed. So I suspect that once you have APO and all these other problems, then you need to wait a few days and you'll probably go for a late clipping. And just know what I did there as well. I made a lot of assumptions just to keep the Viva moving. You know, so if they had this is now serious, I'd have to optimize this. They're not safe for surgery right now. I'd check with cardiology, ICU, and the surgeon about what time frame we have, and I'd try to optimize them for that time frame and proceed with late clipping. I'm not asking questions. I'm just constructing a reasonable scenario to move forward with. But yeah, good question.
I had a look at this recently, and I think there's also a 2020, like it's just a random Google.
Oh, yeah.
I'm not sure the quality of the study, but it's basically saying that there's changes to ST and T wave abnormality after a subarachnoid is generally, they basically looked at the outcomes. It's unrelated to mortality or myocardial injury. Yeah.
Right. Okay, and so you've given me a random Google and a study that we don't know about, and you're giving me some thanks. No,
I was asking the same question, that's why.
Okay, so yeah, severe cardiac dysfunction is only in 2.9%, resolves over 4 to 5 days. So a lot of these things are reassuring. But in the worst case scenario, hopefully you have a plan of attack to, to discuss this. So early or late surgery. So when early is within 48 hours of subarachnoid, there's a decreased risk, rebleed risk. Also facilitates treatment of vasospasm, especially trying to get that hypertension going, which you would be really, not wanting to do if they had an unsecured, unclipped aneurysm. And it also avoids the complications due to lengthy period of bed rest. Now, the disadvantages are maybe increased risk of intraoperative rupture due to less time for the clot for organization, and maybe there's poor operating conditions because of brain edema and mild degree of hydrocephalus, which is common. So what are your intraoperative goals? My main things are preventing rebleed, maintaining CPP and oxygenation, and then I've also just added optimizing surgical access. So that's good. Excellent. Okay, you have a 50-year-old female, day 1 post-subrac for clipping. What is your preparation prior to induction?
So keeping in mind the goals that was outlined at the question, our aims, in addition to ensuring we are in an appropriate centre with post-op facilities to care for this patient, would be to attach appropriate monitoring with a pre-induction arterial line to target those goals. Our aims are to prevent profound sympathetic stimulation of laryngoscopy and neurointervention. And this could be done with a TEVA anaesthetic, with remifentanil, and with concurrent use of boluses of lignocaine or beta blockade at the time of.
Andrew, you're going really well, and I feel like you can keep talking for a lot of things. So I get a good feeling about what your content's going to be. Now I want you to know what your framework is before you keep going.
Yeah, so I probably should have said the goals would be to attach appropriate monitoring, consider the medications and the equipment required for induction and monitoring during the case, and a plan for post-operative wake-up and disposition.
Sounds good. Okay, so that's good. That allows me now to probe the things I wanted. So besides standard monitoring, what else do you want?
So a pre-induction arterial line and reliable IV access in the form of a 16-gauge cannula.
Anything else?
I would consider putting in a central line for potential requirement for vasopressors or dilators during the case.
Sounds good. Look, and just because this is not standard for me, but temp probe, maybe an IDC, BIS, as well as neuromuscular monitoring. I know that's probably standard in some places, but I just offer that because that's not ANSCA mandated monitoring. Good. I like your categories because they're general, and I'm not really going to ask you about the drugs necessarily. Great, you've got your staff, you've got your assistants. I would go through that quickly because I want to get to the points that will get me marks. How about the intraoperative surgical stuff? What are you expecting?
So in addition to maintaining optimal surgical conditions in terms of depth of anesthesia and paralysis and those hemodynamic goals, you would want to think about anticipating potential complications such as intraoperative bleeding, profound sympathetic stimulation, increased intracranial pressure. And so this would require having a preoperative grip and hold, medications to treat increased intracranial pressure.
Yeah, that's good. So I actually made this slide quite a few years back, and I think I'd actually add to it. So, in addition to my usual preparation, I would do a bunch of stuff. So some questions, again, you're not going to have all the factors that will make you remember stuff. So, either just having that patient surgical anesthetic factors, allows you to talk about lots of things, and maybe even having pre-op, intra-op, and post-op just to cover lots of things. So I'd actually add more to this slide now that I think about it. Potentially I was thinking about a very specific circumstance of intra-op, but yeah, often with these cases besides all the usual things. I'm also thinking about far more surgical issues than I normally would. And I'm thinking far more about positioning of the patient. And I do like what you said about, you know, avoiding sympathetic stimulation at all the different points. And there's quite a few points of sympathetic stimulation when you do a neurosurge case, which we will go through. Good. So let's say, I might go back down to Carolyn. Carolyn, what do you do for your anesthetic induction? Say there's a grade 3 subarachnoid. What's your anesthetic induction?
Sure. So this is a critical induction, and my aims for induction is to maintain hemodynamic stability. So both maintaining cerebral perfusion pressure, but preventing an increased rise in blood pressure. And towards this end, I would induce the patient with 20 mics per kilo of alfentanil. You said they were grade 3, didn't you?
Yep.
Right. 1 to 2 milligrams of propofol and 1 milligram per kilogram of rocuronium.
Was that 1 to 2
with a
kilogram of propofol, or literally 1 to 2?
Oh, per kilogram, sorry. Yeah. Yes.
Of course.
Thank you for correcting me. Yeah, 1 to 2 milligrams per kilogram, thank you, of propofol. Rocuronium, 1.2 milligrams per kilogram as a modified rapid sequence induction.
Yeah, fantastic. So I like that you said your priorities, because again, I don't want you to have cliches of what you're saying, but if you are going to say certain cliches, then just get it out quickly. But I like that you started with the priorities that, look, I just want to maintain hemodynamic stability. For me, that's maintaining CPP oxygenation, and I want to prevent a rise in transmural pressure gradient, which is what you mentioned about for avoiding hypertension. And then your induction was very much towards that. You know, you're giving decent enough doses of propofol and and alfentanil to make sure that that's the case. So everyone's got their plan of whatever they're going to do. Doesn't matter. This is what I've just written that I would do. And I would have extra stuff ready in case there's any sudden rise in heart rate. So now let's say this patient was more urgent. So next hypothetical, this patient, let's say they're unfasted, but they need, the neurosurgeons want to go ahead. You're happy to go ahead for early clipping. They're unfasted. Clearly written that wrong, sorry. Would you still do an RSI in this patient, or would you do a carefully titrated opioid induction with REMI for stable induction? What would you do, Carolyn?
So this is a tricky situation, and I think there's not necessarily a right or wrong answer, and you have to balance the risks and the benefits of doing either. Mm-hmm. My option would be to do a carefully titrated opioid induction for a stable induction, recognizing the risks of aspiration, which I would try and mitigate by other means if I have time.
What other means?
So I could give the patient sodium citrate. I would give the patient sodium citrate prior to induction. If I had time, I would have given them maybe ranitidine or a PPI beforehand, ensure that I have sucker under my pillow, and have the patient head up, which I would be anyway for ICP management, and just being prepared to intubate the patient emergently if needed. And with gentle bag masking, so I'm not going to insufflate their stomach. And this is because I recognize the risk that if I do an RSI and I significantly increase their intracerebral pressure, then this patient could have a rebleed and potentially cone, which is going to kill them. So, you know.
And you've got data to back yourself. Risk of aspiration is lower than the risk of rupture at induction, and the mortality is far worse with induction. So that's great. Everything you said, I like the way you said it. Was, you know, you're saying it's a balance of risks. I think that the worst thing here is really I would do everything to mitigate against the aspiration risk. These are what I do, but I'd make sure the patient was deep enough and stable enough before intubation. I think that's a really good answer. Good. And as we were just talking about before, so we probably all know the critical times during the surgery. There's quite a few points here, unlike every other operation where it's literally induction, incision, and extubation. This is induction, pins, incision, dura opening, hematoma removal, clipping, and extubation. It just goes to show that, you know, that's why in neurosurge, you know, you're right there at the bedside. You're always, you know, you're always on. You're wondering what is going on at these times, and potentially that's why running REMI and things like that is so much, you know, more relaxing for us during these neuro cases, because you know that there's always opioid, very effective opioid at the doing what it's doing whenever it's needed. So Maybe you guys can write out and think of this really broadly. I'm pretty sure this was a SAQ back in the day. How can you prepare for these critical times? So take a minute and think very broadly. What are all the things you can do to make sure that this patient will be okay and not have a hypertensive response?
Ooh. My zero knowledge of neurosurgery. I think I'd split this into like potentially patient, surgical, and anesthetic factors. Most importantly, it's the surgical factors, because critical times, the only person who knows when critical times would occur, besides the anesthetist on induction and extubation, is the surgeon. So close communication with the surgeon is very important to be involved and be informed about the critical times that we will need to be monitoring for. And the patient factors, we can potentially pre-optimize the patients by, the whole point of this is to ensure that there is no hypertension and increase in intracranial pressures and increasing bleeding. So by reducing intracranial pressures by giving dexamethasone or preoperative mannitol.
Cool. I want you to move through it faster now. So yep, we're going to manage pressures. You're going to manage surgical communication. Keep going.
Yeah, and then and the anesthetic factors is making sure that there is adequate depth of anesthesia, utilizing the anesthetic medications and opioids, and also keeping the patient still with ongoing use of neuromuscular blockade.
And what do you do if the pressure suddenly spikes? What can you do?
So you make sure you've got a contingency plan for blood pressure control, such as increasing use of anesthetic medications or antihypertensives such as hydralazine or GTN.
Hey, David, your answer is better than mine. So just to let you know that you may have not studied it, but it's still better than mine. So the fact that you did it, the patient anesthetic surgical, actually really helped you out, even though you haven't studied it or whatever. So you're right. You know, the fact that you're communicating with the surgeon, I haven't got that there, but that is absolutely what I would do in real life, and I haven't even written it down. I would monitor for the problem, adequate depth, so patient stuff, adequate paralysis, adequate analgesia with REMI and nerve blocks, and then medications if something was to happen. So that was a really good answer. Excellent. Cool. It looks like if you study for this exam, it makes you worse. Just do what David's doing. Okay, how to optimize surgical conditions. I've got 3 categories here, and this is probably important enough that it's worth you guys writing it out just to get used to formatting this and writing it out. So say a surgeon says there's a tight brain and they need you to fix it. The format that I go through is positioning stuff, pharmacological, and physiological. Those 3 categories really help me to kind of sort out stuff. So maybe the next exercise we can do, maybe take 2 minutes again under positioning, pharmacological, and physiological. Positioning is actually a few things, not just positioning, but it helps to be in that, the kind of mechanical things as well. So positioning, mechanical, pharmacological, physiological. I want you to just put as much stuff there.
So for positioning, I discussed having slight head up. Yep. So tilt of 10 to 30 degrees, having the neck straight if that's okay with the surgeon as opposed to one side, ensuring that tube ties are not obstructing venous return from the brain. For pharmacological management, use of mannitol, hypertonic saline, ensuring that the patient's paralyzed. And then for physiological, no unnecessary PEEP. You can aim for an arterial CO2 of 35 millimeters of mercury, but if you need to temporize, you can go down to as low as 25, just to try to bring down the ICP acutely. Maintain tight glucose control. So I think in some centers aim for a blood sugar level of less than 8, but also avoid hypoglycemia. And then if you have the option of drainage of CSF, for example, through a lumbar drain or an EVD, potentially letting out some CSF.
Yeah, fantastic. That's really good. So in this format, I'm allowed to, it facilitates me doing things in order of the speed of what I can do them, really. But yeah, so head up, loosen ties, collar. I just put PEEP and intrathoracic pressure in that positioning category, but you're right. And pharmacological, I got a whole bunch of stuff: mannitol, furosemide, give muscle relaxant. And I love this term, avoid nitrous. Don't think anyone's using it, but hey, mention it. Maybe it's a mark. Decrease volatile, potentially start TIVA, and give a bolus of thiopropofol, and then physiological. These are all, it's ensure there is good blood pressure control, mild hypercapnia, as you mentioned, and BSLs, as well as the obvious stuff, which is oxygenation and pH has to be pretty tight as well. Excellent. But I love that you mentioned the surgical drains as well. That's really good. So again, better answer than me. Nice one. Again, after the bone plate was removed and as the dura was being opened, the surgeon says the brain is tight. When they say it's tight, it just means that pressure seems to be high. What can you do to facilitate surgical exposure and decrease ICP? So literally just what Diana said. So I would do all the positioning, farm, physiological things, and add on surgical things as well, because they might be able to do some CSF drainage with the EVD. Now, the surgeon says the sudden increased bleeding. So the incidence is about 2 to 19%. That's a pretty big range. You're hoping your surgeon's in the 2% range. The stage of operation affects the outcome. So it's worse at induction. That makes sense because if you can't really clip the aneurysm because you're not all the way in, obviously there's going to be far more downtime with that. The first sign can be a sudden sustained increase in blood pressure and brady, so essentially Cushing's response. And really your aim is to maintain CPP whilst facilitating surgical exposure. And so there's always a problem with this because they're not always in line with each other. You know, maintaining CPP may be good for the brain, but really bad for surgical exposure. So some of the things we'll do, controlled hypotension is controversial, aggressive volume resuscitation, and if a temporary clip is used to gain control of a ruptured aneurysm, return the systolic blood pressure to normal to improve collateral flow. Just a few things before we get onto it. Would you extubate the patient? So what factors would influence your decision, assuming normal airway, ventilation, and nil other complicating pathology? So yeah, obviously you go through a whole process of, you know, assessing this patient from an airway, breathing, circulation point of view, making sure that that's all pretty stable. And then generally speaking, the higher grades, knowing that there's a lot of problems with grading these lesions. Higher grades generally will require mechanical ventilation, lower grades probably not. And then patients who may have some kind of aneurysm affecting the airway protective reflexes may also have a prolonged intubation. So I thought I'd just chuck that in there because it's an interesting thing that I didn't think much about. I think a lot of these decisions will be neurosurg anyway, but or we'd consult them and get their experience on this. Okay, so after all of that, your patient fails to awaken post-anesthetic. Describe your approach. This is one of those really annoying questions because there's so many, your conscious state depends on so many things going right. So I think this is another one that's really useful to train for.
I'd start by scanning my monitors, ensuring that the patient has adequate oxygen delivery, CO2 clearance, and blood pressure. I would consider the pharmacological causes, specifically neuromuscular blockade. So I'd perform a train of 4 to ensure adequate reversal. I would review what opioids, benzodiazepines, and anesthetic agents have been given. I would be unlikely to reverse them in this context, but would allow adequate time for them to wear off. I would perform a blood gas to look for physiological causes of failure to wake, such as sodium, hyponatremia, or hypoglycemia. And I would consider whether the original pathology might be the cause, and it may well be appropriate to get a CT brain if all of the above have been excluded to look for an intracranial bleed as a cause for loss of consciousness.
Yeah, that's really
or seizure, for that matter, would be the other kind of pathological cause.
Yeah, absolutely. No, that's really great, Ben. So what I like is that you got through that really quickly, really efficiently, and talking about your management as you went along. So just to clarify what you said, so physiological, I'll make sure that my oxygen, my CO2, pH, temp, blood pressure are all normal. So my physiological variables are normal. Venous gas is the quickest way to get a BSL and sodium in a hurry. So those are really the things I care about physiologically, pharmacologically, neuromuscular monitors, check for reversal of everything, check my drug chart, how much opioids, benzos, volatile profile is left. And then specifically if I've done any other weird things like local anesthetic injections around, depending on what the procedure was, like maybe there's not this case, but an eye block case, maybe you had local anesthetic spread or a high spinal converted to a GA. Just think of all those random things that could do it. And also prior drug intoxication could also do it. And then after all of that, that's not too much, like it's easy to get through most of those causes and then straight to neuro. Is this a stroke? Is it, an event? Is it seizure? Or is it something more interesting and wonderful? Good. So day 4, post-subarachnoid hemorrhage, the patient becomes disoriented and developed hemiplegia. Ben, what's going on?
So this is a delayed neurological. So I'm trying to remember what the correct term is, but it's vasospasm. But vasospasm. We're meant to call it something else now, aren't we?
Oh, are we? Okay, good. That's new to me. You have to tell me what do we have to call it?
Oh, it's something like delayed neurological impairment or something, which is the kind of catch-all term that includes, because vasospasm's a kind of radiological diagnosis, I think.
Ah, okay. So delayed neurological deficit.
I think that might.
Does anyone know what I should be calling this?
Yeah, I think
I'm familiar with
delayed deficit.
Okay.
So delayed neurological deficit is the umbrella term for a patient that develops any kind of, obviously neurological deficit after a subarachnoid hemorrhage, and then vasospasm is a particular cause of that.
Excellent. And that makes so much sense. It seems very, it's a difficult diagnosis, and you're classifying constellation symptoms that could be many things with that. So that actually makes a lot of sense. So clinical diagnosis is from altered conscious state and focal neurodeficit. Investigations that are required. So CT is often normal. Transcranial Doppler shows increased cerebral artery flow velocity. But angio is the gold standard for cerebral vasospasm. But unfortunately, only 60% will actually have some vasospasm, but only half will have neurological deficit anyway. So it seems like it's pretty much a tricky diagnosis all around. And fortunately, I don't have to worry too much about that. Let's do, maybe write this out. So prevention of vasospasm. So just get some notes down. How do you prevent vasospasm? Take 2 minutes to do that. And then kind of the more specific ones. So yeah, we did go through it before, worthwhile just because it's, I guess it gets commonly asked. Imodipine at those doses, hypervolemia, hemodilation, hypertensive treatment or therapy. And then some of these extra things to make a complete answer: balloon angioplasty or intra-arterial papaverine, normal CO2 and oxygen, normal BSLs, careful monitoring. And then the fact that there's no evidence supporting the routine use of antifibrinolytic steroids or anticonvulsive prophylaxis. And that's exactly right. So as I mentioned before, yeah, we're not really doing hypervolemia anymore. And it's more historical that that was one of the things. So that's really good.
The blood pressure target of 160 to 200, is that historical, or is that part of a modern guideline?
Actually,
for acute aneurysm?
Does anyone want to share experience about that?
The most recent vasospasm treatment I had to do, we had 140 to 160 as that patient's target, but I think that was based on their GCS improvements for that particular patient. So I'm not sure if that was specific, guideline related or patient specific, but that was the goal that we had for them when we took them around to DSA.
Yeah, okay. And Nicole, you've done a bit of neurosurgery, did you have particular blood pressure targets that you were doing?
I believe they based it around the patient's baseline, or as was just mentioned, the target where they get improvement in their neurological symptoms.
Yeah, excellent. And that makes a lot of sense, isn't it? Like this blanket rule of 160 to 200 feels a bit odd. And obviously these are clipped aneurysms as well. Excellent.
I know the unsecured aneurysm SNAC guidance is 110 to 160 systolic, or to 140 if they're alert, which I know is probably not as good as titrating to the patient, but for a Viva, it's pretty useful to just pull a guideline figure out if they ask you.
Which guideline?
Did you say that was for unsecured?
For unsecured, yeah.
Yeah, it seems quite high, I would have thought, for...
So that's the Society for Neuro-anaesthesia and Critical Care.
Yeah, cool.
SNAC, is that?
Yeah, SNAC, which is a good acronym, I think.
Yeah, that's right.
Same for the 2020 TBI guideline for transfer. It's 110 to 150 systolic that they recommend.
Okay, it's still getting up there, but that's good. Thank you so much for offering that information. So these guidelines are saying unsecured aneurysms you'd aim at between 110, say, and 150 or 160, depending on which guideline it is. Excellent.
Or 140 if the patient's alert.
Or 140 if the patient's alert. Okay, good to know. Look, just to give you a bit of background, this exam, I didn't get asked a single evidence-based paper question. But I thought for this is probably useful because there's a lot of history behind, I guess, the stuff that we do. So ISAT was about coiling versus clipping. So coiling decreased the relative risk by 22.6%, absolute risk by 6.9%. And at 1 year, the absolute risk reduction was 7.4%, and the survival benefit continued to 7 years. So this trial, however, had problems with it. The sample bias of 69% of eligible patients were excluded, so it seems quite high. 31% suitability for coiling, which was lower than usual, and the CLIP group had a 50% higher pre-op rebleed. So the CLIP group did much worse than comparable centers. So that's a bit about ISAT. And then IHAST is mild intraoperative hypothermia during surgery for intracranial aneurysm. And so with this one, essentially intraoperative hypothermia did not improve the neurological outcome after craniotomy among these good grade patients. I think it was up to grade 1, 2, or 3, or good grade patients with aneurysmal subarachnoid hemorrhage. So the criticisms of that trial were they were not cold enough and not early enough. And so again, just interesting to know that these were the studies that were around the subarachnoid space. So coiling, it's different. So the Guglielmi detachable coils, microcatheter inserted via the femoral artery until occlusion of an aneurysm is achieved. And again, according to that, a better 1 year and 7 year survival, but risk of late rebleeding. Pre-ops is similar workup, but intraoperatively, you've got all the issues of having, you're in a remote environment, there's radiation, radiological equipment around, contrast, heparin, but otherwise a lot of the same goals. You're maintaining CPP, avoiding transmural pressure gradient increases to avoid rupture. And if something bad does happen, having everything in place to manage that. So I've got this patient here, a 40-year-old female for coiling of a grade 3 subarach aneurysm. No allergies, no medications, usually fit and well. You're in the angio suite, remote to theatre, and the patient's intubated with volatile and remifentanil running, art lines in situ of 16 gauges in the cubital fossa. The interventionalist looks suddenly distressed. What do you do? So does anyone want me to have a go just asking questions of them? It's good for you.
I'm happy if no one else is jumping up, Lahiri.
Go for it, Ben. So what do you do with this?
So I would want to know the cause for the interventionalist distress. So I communicate with them, and I would scan my monitors looking for any physiological perturbations. And
that's great. So the first thing you want to do is what is the problem? What are essentially the two problems that have slightly different management plans? What are the two problems that could be?
So there's bleeding or they embolized the wrong bit.
Yeah, fantastic. They're either clotted something or they're bleeding, so something's bleeding. So two different pathways. Let's say this is a massive bleed. It's all bad. What are you thinking?
This is a crisis situation. The interventionalist needs to be able to take control of the situation rapidly, and I need to support that. The main therapies that I'll be able to administer in order to help the interventionalist is reversal of any heparin that's been administered and a transient reduction in blood pressure to allow them to take control of the aneurysm. Meanwhile, trying to maintain CPP by optimizing intracranial pressure, as we described before.
Yep. As you do that, you provide those conditions for the surgeon. The surgeon keeps trying to get hold of this aneurysm, but it looks like there's actually torrential blood loss. There's quite a large aneurysm, torrential blood loss. Your blood pressure is trending down to 70. You're requiring more and more aramine, so you're on 20 mils an hour. So 10 milligrams an hour of aramine, and you're giving quite a bit of fluid. You've given a liter already, and you've seen a lot of blood in the sucker. What do you do? This is a coiling or a clipping? Sorry, this is a coiling, isn't it? I'm going to completely change. I've totally messed that situation up. So let's say the interventionalist is worried that there's a bleed. The surgeon isn't able to get control of this. You're getting the patient bradycardic and hypertensive now.
Okay, so this is deeply concerning for essentially coning, Cushing reflex. I think I would hyperventilate the patient to try and reduce intracranial pressure, and I'll administer osmotic therapy. So I give 0.5 gram per kilo of mannitol. I would aim to help the interventionalist by providing a transient ventricular arrest with adenosine. I would give 0.3 to 0.4 milligrams per kilo of adenosine. And I would also ensure that the neurosurgeons had been contacted and neurosurgery theatre was being prepared, as it sounds like the interventionist is going to be unable to get control and this is going to need an emergency craniotomy.
Anything else you want to prepare? Let's say you're getting the theatre ready, you're getting ready for transfer. Is there anything you're expecting?
So I'm expecting that this is going to be an unstable transfer to theatre. So I need to ensure that I've got portable monitoring, that I've got a skilled airway assistant. The second pair of hands as an anaesthetist would be really appreciated, as well as a tech that knows the way. I would have drugs available to manage changes in blood pressure and further osmotic therapy in hand. And I ensure that I've got the equipment I require for transfer.
Good. Is there a professional document on that?
ANSCA PS52.
Yeah, sounds good. I do want you to mention it. You sounded sharp anyway. I feel like it's one of those things there's a game we're playing. There's a professional document. I'll do that. And hopefully you just move on and they go, yep, great. This person knows what they're talking about. But that was a good answer. Anything else in theatre once they open that you're worried about?
Blood loss in terms of management of anemia and blood loss becomes a problem, because with the cranium open, this may be torrential blood loss, and therefore I'd insert a second large bore IV access and prepare a level 1 infuser, ensure that the blood bank has been contacted and that we've got cross-match blood ready.
Yeah. Ben, that was a really good answer. I really like the stages where you went through it. Firstly, occlusive or hemorrhagic, getting all your other stuff sorted out, but making it, making the conditions as best they could for the surgeon in a very targeted fashion. And then depending on what I said, I obviously made the situation get very bad. Immediately, it's all about getting the patient to theatre, preparing them for theatre, transfer to theatre, and then preparing for massive blood loss. So that's great. So the complications you might get, vasospasm, so you just have to withdraw the catheter, and you might give some intra-arterial nimodipine or other substances. Rupture of the hemorrhage is its own thing, which we just talked about. And you also mentioned reversal of the heparin, which is great. And then if it is occlusive, then potentially it's hypertension, other angio procedures, and procedural administered drugs as well.
Large, I think they were actually off the MCA, but nonetheless, they were deep intraparenchymal, circle of Willis lesions, with a very good surgeon. I'm like on edge at the edge of my seat, and I'm just watching the screen when they're doing it. But they make sure that they've got both adenosine in theatre and appropriate volumes of it, so you can give graded dosing if you need it, or repeated dosing, and also having what they use the Induction in green as well, not for clipping management, but having it ready to go in the theatre when they want to give it for their intra-op sort of angiogram regarding the temporary clip placement.
Yeah, okay. And so how much are you giving of the adenosine?
Well, you'd give essentially like this similar doses, so 6 milligrams, to seeing if they get, because you essentially just want to pause so they can see the vessel for a moment without pulsatile flow, so they can put a clip on. So enough to make us wince and stop the heart.
Yeah.
Hi. There's a Blue Book article in 2017 on this specific circumstance and use of adenosine. And in there, they recommend a dose of 0.3 to 0.4 milligrams per kilo. So that means that a sort of 70 kilo patient is going to get about 24 milligrams of adenosine, which seems pretty extreme. Yeah. But they're basing it on a fact that obviously when you're doing it for a sort of a cardioversion, you don't mind if it doesn't work, whereas you kind of really need it to work.
Yeah.
So they recommend that higher dose because essentially it pretty much guarantees you ventricular standstill for 20, 30 seconds. Wow. But it is more associated with arrhythmias afterwards.
Yeah, no, that's really interesting. And thank you so much for that article. That is so useful. And this is really recent, isn't it? Like 2018 guidelines by it would seem that these are a very specific, was it Society for Neuroscience and Anesthesia and Critical Care? Have they got much of a presence in other guidelines, neurosurge wise, or?
I haven't. I was just looking now to see where I got those blood pressure targets from, and I don't think it's them.
Yeah, I couldn't find it when I had a look. I found something from the AHA about an unsecured aneurysm, though, suggesting a blood pressure less than 160.
Oh, yeah.
And a MAP no greater than 110, but I couldn't find those other unsecured blood pressure targets.
This seems very much the emergency management rather than maintenance of stuff, doesn't it?
I think Up to Date has a few ideas as well, but
I can't read Up to Date. Anyway, let's keep going. Thank you so much for providing that information. And again, your experiences is really, really valuable, and thank you for that. So intracranial vascular lesions, let's get cracking. So to me, this, what is this in a nutshell? It's craniotomy plus position, plus major bleed risk, and maybe even venous air embolism as well. And that's just kind of how I try to categorize the issues that are most relevant to this case above all other cases. And what are the key steps to rupture management? We've gone through a bit of them as well. Get help, ABCs, induce hypotension, aim of systolic blood pressure 60 to 80, fluid and blood, carotid compression, temporary clip, and obviously adenosine as well, which we've just been talking about. So it's so interesting that we're used to giving 6 to 12 milligrams, but we really just need this to work. So giving 24, 30 milligrams of adenosine, and that means that it will last that 10 to 15 seconds or whatever they recommend in that SNAC article. Seems a bit very aggressive, but it makes a lot of sense that that's what it takes to put this clip on and get control of the situation. Then postoperatively, hyperperfusion, worrying about cerebral edema and increased ICPs. So again, a lot of the same stuff, just more chronically managed. Now, typical case in RMH, I'm sure, 50-year-old male, AVM, clipping in the posterior fossa, sitting position, consultants getting coffees. Now, suddenly the patient becomes tachycardic with an end tidal CO2 drop of about 10 millimeters mercury. What do you think's going on? Anyone?
They've had air embolism.
Yeah, venous air embolism, absolutely. So the surgeons worry about air embolism. What do you do? Yeah, it's probably a good thing I want everyone to write out an approach to cover as much detail. Remember, this is obviously, there's a lot of things you need to do. So categorize the things you need to do. So that way you can talk about them by listing the category of what you need to do, and then you can tell the story or give the detail of it. So take a minute now to do that. First of all, how did you categorize your approach to this?
So I suppose I think of it as a crisis, essentially. So you kind of think of an ABC approach, but an intraoperative crisis involves sending for help, notifying staff. So I'd kind of think of, sort of alerting the surgeon and everyone in the room, probably calling for help externally, and then ensuring that airway is still patent, that the patient's still ventilating, switching to 100% oxygen, and then just checking the patient's hemodynamics as well.
That's all good. So I'd classify that as all the general things, which are definitely worth mentioning. Yeah. I get help, I mobilize the team, I'm worried about the ABC, so I check that everything is as optimized as possible. Then the critical stuff of this is going to be the venous air embolism management. Do you have an approach to the venous air embolism management, or what do you do for that?
So not really. I think there's sort of surgical treatment and then potential anaesthetic treatments.
Yes.
So I think surgical treatments might be, I think sort of flushing the field with saline and covering the field, I think. And then anaesthetic treatments involve this sort of supportive care, 100% oxygen to try to reduce the gas in the venous space. I think potentially sucking blood from the central line might be described as well, to reduce the burden of air.
How do you stop further entrainment of air besides the saline? What else could you do?
Packing the field as well.
Yeah, you could pack it. Literally just close off the field. Anything else?
So covering. And and I suppose if you increase the CVP as well, so or central pressure, so PEEP and that sort of thing.
That's hard to do because of the position of the patient.
So changing the position, so getting the patient head down if possible.
Yeah, and you probably have a discussion about all of these. What if air embolism? Let's have a plan to, flood saline, change the position of the patient, and a lot of the stuff that you mentioned. Look, there's a really good CEA CCP article, I think from the 2000s actually, that goes into this kind of category. So prevent further embolism, decrease size of embolism, and promote forward flow. So, a lot of the stuff you had was absolutely correct. When I categorize this, I feel like it comes across, with a certain amount of organization that, again, in real life, you're able to tick these off, and in the Viva, you sound sharp. But, you got a lot of the points. So flood area with normal saline, might valsalva the patient, change the position of the patient. They used to have it, where I trained, they used to put a tourniquet around the neck as a strategy. And so if there was air embolism, they tightened the tourniquet instantly, but temporarily, whilst sorting out everything else and setting out the position. So that was just one of those peculiar things. And you mentioned CVC aspiration. Decreased size of embolus you mentioned, which is 100% oxygen and maybe aspiration as well. And then promote forward flow, because now you've got a big airlock. So CPR, fluid, adrenaline, Durant's position, which is left lateral head down as required. But that's good. Excellent. So summary slide, just from what we've gone through, we went through a whole bunch of subarachnoid stuff. Just to recap, the preoperative framework stuff, which was severity, stability, cause, complications, and then all the fancy management things that might have implications as well. We went through a couple of trials and AVMs. Any questions on any of that before we move on?
Hi, Lahiri. Just thinking practically about this. I've really done very little neurosurgery. Presumably somebody having this kind of thing is going to be in pins. When it comes to positioning, are you talking about sort of subtle changes with the table, or are you talking about kind of flipping the person onto their side and taking them out the pins? And is that going to ruin your surgical exposure to actually fix the entrainment?
Yeah, and the question is, so the answer is, again, I haven't done neurosurgery in a long time, but also, even if I did do a lot of neurosurgery, every different institution, every different surgeon potentially has a different preference. So I'm saying ideal things, but I would always have this discussion beforehand. Like even when I do any kind of head neuro, I go, hey, what's the risk of this? What's the risk of that? What are we going to do if that happens? So it's all just the timeout stuff. What are we expecting? What are we going to do? And we all just preempt it. So yeah, there may be some tables now that the pins or the whole table can be shifted in a position. I don't know, but things will always change, and we prepare for that change by having the discussion.
Nicole here. I was involved indirectly with the VAE with Kate Leslie at Royal Melbourne a few years ago, and they basically moved the whole table head down and side on with the clips still in, but obviously they discussed that with the surgeon and then did CPR. So yeah, I think they just have a plan in advance, like Lahiri said, but yeah, they often just move the whole table like a Trendelenburg type setup.
Yeah, that makes a lot of sense. Just moving the whole table just keeps all the things in place without having to worry about the pins.
You'd also realistically be very unlikely to be doing a sitting neurosurge procedure now, from what I understand.
Yeah.
Talking to some of the neurosurgeons about this, just out of curiosity, they were saying that they might have done one or two with one person at this centre part of way through their training, but it's so rarely done that you'd be more likely to be in a prone position. So it's going to be, you may be still in pins, but you're not starting from a sitting up position.
Yeah, good to know.